Follicular thyroid cancer, Wikipedia audio. Follicular thyroid cancer or follicular thyroid carcinoma accounts for 15% of thyroid cancer and occurs more commonly in women over 50 years of age. Thyroglobulin can be used as a tumor marker for well-differentiated follicular thyroid cancer. Follicular cells are the thyroid cells responsible for the production and secretion of thyroid hormones. It is impossible to distinguish between follicular adenoma and carcinoma on cytological grounds. If fine needle aspiration cytology suggests follicular neoplasm, thyroid lobectomy should be performed to establish the histopathological diagnosis. Features sine qua non for the diagnosis of follicular carcinoma are capsular invasion and vascular invasion by tumor cells. Still, focuses of the capsular invasion should be carefully evaluated and discriminated from the capsular rupture due to FNA penetration resulting in waft. HMGA2 has been proposed as a marker to identify malignant tumors. Classification. Treatment is usually surgical, followed by radioiodine. Some studies have shown that thyroglobulin testing combined with neck ultrasound is more productive in finding disease recurrence than full or whole body scans using radioactive iodine. However, current protocol suggests a small number of clean annual WBS are required before relying on TG testing plus neck ultrasound. When needed, whole body scans consist of withdrawal from thyroxine medication and/or injection of recombinant human thyroid stimulating hormone. In both cases, a low iodine diet regimen must also be followed to optimize the take-up of the radioactive iodine dose. Low-dose radioiodine of a few millicuries is administered. Full-body nuclear medicine scan follows using a gamma camera. Scan doses of radioactive iodine may be I-131 or I-123. Follicular carcinoma tends to metastasize to lung and bone via the bloodstream. Papillary thyroid carcinoma commonly metastasizes to cervical lymph nodes. Recombinant human TSH, commercial name Thyrogen, is produced in cell culture from genetically engineered hamster cells. Hürthle cell thyroid cancer is often considered a variant of follicular cell carcinoma. Hürthle cell forms are more likely than follicular carcinomas to be bilateral and multifocal and to metastasize to lymph nodes. Like follicular carcinoma, unilateral hemithyroidectomy is performed for non-invasive disease, and total thyroidectomy for invasive disease. The overall 5-year survival rate for follicular thyroid cancer is 91%, and the 10-year survival rate is 85%. By overall cancer staging into stages I to IV, follicular thyroid cancer has a 5-year survival rate of 100% for stages I and II, 71% for stage 3, and 50% for stage 4. Approximately one-half of follicular thyroid carcinomas have mutations in the RAS subfamily of oncogenes, most notably HRAS, NRAS, and KRAS. Mutations in MINPP1 have likewise been observed, as well as germline PTE and gene mutations responsible for Cowden syndrome, of which follicular thyroid cancer is a feature. Also, a chromosomal translocation specific for follicular thyroid carcinomas is one between paired box gene 8, a gene important in thyroid development, and the gene encoding peroxisome proliferator activated receptor gamma 1, a nuclear hormone receptor contributing to terminal differentiation of cells. The PAX8-PAR1 fusion is present in approximately 1/3 of follicular thyroid carcinomas, specifically those cancers with a T translocation, permitting juxtaposition of portions of both genes. Tumors tend to carry either a RAS mutation or a PAX8-PAR1 fusion, and only rarely are both genetic abnormalities present in the same case. Thus, follicular thyroid carcinomas seem to arise by two distinct and virtually non-overlapping molecular pathways. Treatment. Initial treatment. Finding disease recurrence. Hürthle cell variant. Prognosis. Associated mutations.